A very good evening, everyone. I am G. Arunagiri from Government Tiruvallur Medical College, and I will be hosting this session today. I wholeheartedly welcome our AATRAL Star Faculty, Dr. Apeksha Anand ma'am, and our presenter for today's session, Dr. Srijhaa ma'am. Over to you, ma'am.
Thank you. Shall we start? Or we'll
Yes.
wait for 5 minutes. Okay.
Participants are still joining.
I hope all of you are energized today. So nephrotic is a simple topic, and I want all of you, the second, third years, if you are around, also to be answer and active. So since it's not as long as CNS case, so I thought we'll discuss a little more when it comes to history part. So, but we'll finish in the stipulated time of our 1 hour. Okay, and I again have a small presentation at the end for the final points for the exam going students. Okay, I think we can start now. We have around 200 participants. All right. You can share your screen and start. Srijhaa?
Yes, ma'am. Am I audible?
Yes.
Okay. Can I start?
No match today. Yes, no match today, but we won yesterday. Yes, so full energy. Go.
Yes. So, good evening, everyone. I'm Srijhaa from Tagore Medical College, and I'm here to present about a case of nephrotic syndrome. So, I'll start now. A 5-year-old child, Hari, hailing from Tambaram, was brought by his mother, whose reliability was good, with chief complaints of facial puffiness past 7 days, abdominal distension past 7 days, and reduced urine output past 3 days. Next slide. So the child was apparently normal 1 week back, after which he developed facial puffiness, which was insidious in onset, gradually in progression, initially in the periorbital region, which was more in the morning and reduced as the day progressed. Later, his mother noticed abdominal distension, and a day later, he developed swelling in both lower limbs, which started from the ankles and progressed onto the knees. And this was followed by scrotal swelling. He also had history of reduced urine output, which reduced from 8 to 9 times per day to 5 to 6 times per day. There was no history of pain during micturition or burning micturition, no history of fever, sore throat, or skin lesions in the recent past, no history of passing cola-colored urine, no history of headache, vomiting, or seizures, no history of jaundice or pleuritis, no history of passing pale-colored stools or high-colored urine, and no history of altered sensorium. Next slide.
Okay. So, okay. You finish the history and then we'll stop.
Yes, ma'am. And there was no history of passing greasy or bulky stools, and no history of abdominal pain or passing loose stools. There was no history of breathlessness, chest pain, or palpitations, no history of weight loss or loss of appetite, no history of chronic drug intake, and no history of any insect bite.
Okay. So can you go to the previous slide, please? So Srijhaa, so
Yes,
how do you distinguish the swelling? So do you think it has facial swelling, abdominal swelling, and leg swelling? So what do you call it?
Generalized edema, anasarca.
Very good. Okay. So which system do you think is involved based on your history?
Mostly renal origin.
Yes, very nice. So what are the points for renal?
Ruling out cardiac and liver causes.
Okay.
More likely to be renal origin.
Okay,
And
so
also
cardiac,
reducing
where is
output
the
was
swelling
present.
first?
It was in the periorbital region.
Pardon me?
Periorbital region, periorbital edema.
Okay. So cardiac, if it's a cardiac problem, where is the edema first?
Ped edema.
Very good. Okay. So what about liver problem?
Ascites and then ped edema.
Okay, very nice. So at the end of history itself, we all know that we are probably dealing with something renal. So this is a very classical case of
nephrotic.
What do you suspect? Very good. Nephrotic.
Yeah, nephrotic.
So the child will present like this. Okay.
Yes.
So symptom wise, so she has tried to rule out all the conditions. So can you tell us what have you tried to rule out in your history?
Yes, ma'am. With the history of fever, sore throat, or skin lesion, I'm ruling out a streptococcal infection, ma'am.
Okay.
post-streptococcal glomerulonephritis, and same for also passing cola colored urine, which indicates hematuria. I'm ruling out glomerulonephritis. And headache, vomiting, and seizures indicate hypertension, which is more likely to be nephritic syndrome. So I've
Very
ruled
good.
out now. And to rule out a liver problem, jaundice, pleuritis, and passing pale colored stool or high colored urine and altered sensorium, indicating liver failure.
Okay.
And in next slide, we have breathlessness, chest pain, and palpitation that rule out congestive cardiac failure.
Okay. Okay. So your child is, I think, around 5 years. Okay. So if a smaller child, probably 1-year-old child, comes with leg swelling first and then abdominal swelling, so what do you suspect?
Congenital heart disease.
Okay, very nice. So anything else? Okay, this is beyond the box, so probably some viral myocarditis, right?
Okay.
So all these things are common in the CCF. Yes, the causes of CCM may be many. So if the child is smaller, you can also suspect if there is fever, cold, cough, even viral myocarditis, right? The child will present with cardiac failure. Okay. So we'll move on to the past history.
Yes, ma'am. So the child had similar episodes at the age of 3, for which he took medications for 3 months, initially daily and later on alternative days, after which his mother reported that he had no such complaints in the past 2 years. And there was no history of measles and tuberculosis, no history of any drug allergies, and no history of any past surgeries.
Okay. So the mother is aware of the treatment which was going for the child. Does she know the medicine he was on?
No, ma'am. She doesn't really know the medicine, but how often it was given and what its course, she was aware of that.
Okay, that's good. So whenever we are taking something which will relapse or which will occur again, that's one thing we'll either have to mention here in the past history or in the socioeconomic history, that is the mother aware of the course of the illness? Is the mother aware that there is chances of relapse? And mother should always be educated about the complications as well. Okay.
Yes. Okay.
So why do you want to know about measles, tuberculosis?
They can aggravate malnutrition if present.
Anything else? Any other reason you want to know?
Steroid use in immunocompromised state can cause infections.
Very good. Okay. So it can either cause infection or it can also mask the infection, right?
Infections. Yes.
Right. Okay. So, okay. Next. Okay. Anything significant in the antenatal?
Ma'am. They were uneventful.
Okay. So then we can skip. So uneventful, antenatal, natal, postnatal.
And postnatal history. Yes, ma'am.
Okay. Right. Next.
So immunization history. The child was immunized appropriate for age, and the last vaccine given was a DPT booster. Sorry, I didn't mention that. And
Okay.
option vaccines were suggested by this.
Tell me what you, since you left it blank, a question for you. What are the vaccines given at 5 years? You can tell what is
DPT
given in the government. Yes.
DPT booster vaccine.
And
I'm not sure, ma'am.
Nobody else wants to answer?
PD at 10 years.
Okay, so it's very important for you all to know the national immunization schedule. So if you're going for exams, please read the latest national immunization schedule. Also read about the optional vaccines. So can you tell us what are the optional vaccines were suggested, but the mother said it's not followed? Okay, can you tell me what are the optional vaccines advised?
Pneumococcal vaccine, meningococcal vaccine, varicella, and one more is
okay. So somebody has
influenza vaccine.
Influenza, right? So actually some people have answered as TD. So TD is not given at 5 years. DPT booster only is given at 5 years along with MR. Okay. Yes. So corrected. Please go through your latest national immunization schedule. If you want at the end, I can revise it for you. Okay.
Yes, ma'am.
Then, so okay, now he's almost 5 years. He has not taken pneumococcal. So what is the dose you will give? I know it's a little tough one. Do you know?
No, ma'am.
Anybody else wants to know? Anybody who knows? Yes, we have to give 2 doses. So less than 6 years, you have to give 2 doses. How many weeks apart?
8 weeks apart.
Yes, very good. So you have to give 2 doses, 8 weeks
8
apart.
weeks
And
apart.
once that, if the child is more than 2 years, other than conjugate, you are also supposed to give polysaccharide vaccine after 8 weeks. But if the child is more than 6 years, you can give 1 dose of conjugate vaccine, and 8 weeks later you can give polysaccharide vaccine. Okay, so these are something which are the out of the box questions. Sometimes if you mention optional vaccine suggested not given, the examiner might ask. And if you have not mentioned that line also, they're like, why have you not mentioned? And they might ask it. So be prepared. Okay, then one more is varicella vaccine. So the mother has not taken. So if the child is on steroids, after how many weeks do you recommend varicella vaccine?
Around 1 month.
Yes, 4 weeks. Okay, because it's a live vaccine. So one thing to always remember, when the child is on steroid therapy, you should avoid live vaccines. Okay, because it's on immunosuppressed state. Clear, anybody? Okay. So these immunization things are something you tend to miss, but when you write or comment on these things, you tend to get caught in the things which you have mentioned. So just to know these basic things, at least something about pneumococcal, a little about varicella. Okay.
Yes.
Next, developmental.
So developmental milestones are attained appropriate for age, and the child is studying in first standard and has a above average scholastic performance.
Okay. Next.
So diet history, we followed a 24-hour recall method, and the calorie deficit is around 330 kilocalories, and there is no protein deficit.
Okay.
Socioeconomic history. The child belongs to a lower middle class society according to the modified Kupaswamy scale, and he lives in a Pakka house which is poorly ventilated. 4 members in a single room. They have separate kitchen and toilet. And family history, no similar history in the family. So, summary: a 5-year-old child, first born of a non-consanguineous marriage, presented with complaints of anasarca and oliguria. He had similar complaints in the past, for which he was treated completely. His antenatal, natal, and postnatal history were uneventful, and child attained normal developmental and development, and is immunized till date. And the rumors probably of renal origin, likely to be nephrotic syndrome, with no signs of congestive cardiac failure or any infections.
Okay, good. So she has mentioned everything. So the child history, complications, past history, and then also probably she's thinking of a renal origin with no complications as per history. Okay, you can add that one. As per history, there are no signs of any congestive cardiac, because we are still not examined the child, so we don't know what is the state. Okay.
Yes.
So any doubts till now? Yes. Any significance in family history? Yes. So like normally if it's an acquired nephrotic syndrome, like idiopathic nephrotic syndrome, very unlikely. But then if you are seeing for secondary causes like any SLE or IgA nephropathy or membranoproliferative, so those things sometimes run in family. So we need to know about any renal problems in the family. And if the child is less than 1 year and you are presented with a nephrotic syndrome, you might have to think about congenital nephrotic syndrome. Okay.
Yes.
Okay, next. You go to the exam.
Yes. On general examination, the child was alert, active, and afebrile. He had bilateral pitting type of pedal edema from ankles to the knees. There was no pallor, icterus, cyanosis, clubbing, or lymphadenopathy present.
Okay.
So head to foot examination.
Positive points in head to foot examination.
Yes, ma'am. The child had periorbital edema and facial puffiness. Abdominal distension was present. Scrotal swelling and bilateral pitting period edema was present.
Okay. Next.
Anthropometry, the height of the child was 104 centimeter against the expected 107 centimeter, but it's normal. And the weight was 17 kilograms. Expected was 18 kg, just again normal. Head circumference is around 52 centimeter. Chest circumference 58 centimeter. Mid upper arm circumference was 14.5 centimeter. And abdominal girth was around 60 centimeter.
Okay, so probably his centiles are normal.
Yes.
Okay.
So vitals, the pulse rate was around 86 per minute, which was regular in rate and rhythm, normal volume and character, and no delay. Respiratory rate was 20 per minute. Blood pressure was around 100 to 100 by 180 mmHg, and temperature afebrile. And
Okay,
on
so I
systemic,
want to ask you one thing. Blood pressure, have they told you that we chart in centiles in blood pressure? Are you aware of that? Have they taught you in your respective colleges? See, blood pressure in pediatrics is more based on the centile. We have a BP centile chart, and based on that, we classify more than 90th, more than 95th. So, are you all aware of that or no? No. Okay, yeah, for height centile, yes, you take the height centile and then there are specific charts. Okay, I don't think they're going to ask you at undergraduate level. Probably it's mostly a postgraduate level, so it's okay. Just know that in pediatrics, so based on height for age, so we have centile charts. So based on that, we plot the blood pressure, because pediatrics varies from birth till 18 years. So the blood pressure also varies from birth to, so 180 for a newborn is not normal, right? And for a probably a 16-year-old adolescent also 180 is not normal. So
yes.
it varies. So just know there is a centile chart if they ask. Okay.
Yes.
Right.
Okay. So on system
So once
examination,
again, there are some questions about vaccines, which I'll take it in the end. I'll discuss together. Pneumococcal, there are some doubts. I'll clear it. Okay. So we'll finish and then we'll get it. Okay. Okay. Continue.
so on systemic examination of abdomen, inspection, the abdomen was distended, pharynx full, skin was stretched and shiny, umbilicus everted, horizontal and was slit-like. Corresponding quadrants moved equally with respiration. No visible veins, scars, sinuses, or striae present. No visible pulsations. Vernal orifices were free, and external genitalia, scrotal edema was noted. And on palpation, there was no warmth or tenderness, no guarding or rigidity. Abdomen soft and distended. Liver palpable 1 centimeter below the right costal margin, with smooth surface and round border, and fluid thrill was present.
Okay. So we have fluid thrill. So how do you palpate the organs? What method do you use?
Dipping method.
Very good. So you should see, I since it's a like I'll not be able to demonstrate nephrotic syndrome, it's very important you're very much clear about the abdominal examination. So please read how to palpate, different methods of palpation of liver and spleen. You have to know the hooking method and the conventional method of spleen palpation. Okay, I think somebody else is unmuted. Can you? Yeah, right. Okay. So just read all the whatever book you're following, it's fine, but please read the palpation and they will ask you to palpate. So before palpation, follow all the aseptic precautions, warm your hand, ask consent, and then palpate. Okay, remember this in pediatrics. Take consent from the parent.
Yes.
Okay.
Next slide. Okay. On percussion, liver span was around 8 centimeter and shifting dullness was present. On
Okay.
auscultation, normal bowel sounds were noted and no bruit or venous sound present.
So one more, like somebody has asked, in case of fluid thrill, it's the maximum ascites. How do you tell about the borders? Very right. So sometimes you will not be able to feel the border, but when you are putting the pressure, so when the fluid displaces, you will be able to feel the border sometimes. And the same goes with shifting dullness. If it's tense ascites, then sometimes the fluid might not shift. So it all depends on the child. So I have not seen the child you have examined. So uh, I hope all of you are aware of how to perform shifting dullness. Please read it, and then if you feel you didn't feel, you write whatever you feel in the examination. But if it is a very tense ascites, there is less chances that the fluid gets shifted. But if fluid thrill is present, sometimes shifting dullness is also present if you properly shift the child. Okay. Then one more thing, when there is very minimal fluid, what test do you do?
Puddle sign.
Very good. Do you know how to do puddle sign?
In knee elbow position,
Very good.
auscultative percussion method. We'll do both
Okay.
of it.
Okay. Okay. Then, not. Why do you want to know about the vowel sounds? Is it important here?
No.
What is the most common complication of nephrotic
Peritonitis.
syndrome?
Peritonitis.
Yes.
Peritonitis.
Very nice. So what happens in peritonitis?
There will be guarding and rigidity and
Yes. So there might be chance of perforation, peritonitis, right? So there is chances that there will be absent bowels also. So it's very important. It gets tough with the ascites, but you are supposed to wait for how many minutes to say there is absent bowel sounds? Any idea? Anybody knows? How many minutes minimum? Oh my God, so many messages. I'm missing. No, it's normally 3 minutes. Okay, it's 3 minutes. You have to check for 3 minutes and then only confirm if there are vowel sounds and then tell absent vowel sounds. Okay.
Okay.
So next.
So other system were clinically normal.
Okay, so in case of this, they might ask if sometimes when the child comes in an exam, the child has cold and cough. So if he has any symptoms pertaining to any of the systems, please elaborate that system also. For example, he comes with cold, cough, and then abdominal distension or whatever. So please elaborate respiratory system examination, because pneumonia is one of the very common infections in nephrotic syndrome.
Nephrotic
Okay,
syndrome. Yes.
right.
Okay. So summary.
Yes.
A 5-year-old child presented with complaints of anasarca and oliguria. He had similar complaints in the past for which he was treated completely. On examination, he had generalized edema and severe ascites. His anthropometry were normal for age, and there were no signs of malnutrition, hypertension, or anemia.
Okay.
So diagnosis?
So you have written generalized edema and ascites. So
Severe ascites.
okay.
Yeah.
So I think the generalized edema per se,
Yes.
I mean, okay, it's fine. But then doesn't, you can write generalized edema involving periorbital region, severe as I can put it in brackets, because you don't have to write both. Okay, it's okay, it's fine. Nothing major. I'm just fine tuning of what you have done.
Yes, ma'am. Okay.
Anthropometry is normal, good. No signs of malnutrition, hypertension, or anemia. Okay. So can you tell me why are you very much worried about anemia here? Since you mentioned, I'm asking.
Oh, yes, ma'am. A nephrotic syndrome transferrin deficiency can cause anemia. So to rule that out.
Okay. So whenever you comment anything in your exam summary or whatever, please know why you're writing, because sometimes, most of the time, what will happen is they will catch in that point. They leave everything what good you have done and you'll just get caught why is anemia. So in that tension, if you forget, so you will panic unnecessarily. Okay, so put down points if you are very clear of what it is. Okay. So diagnosis.
So diagnosis is a case of idiopathic nephrotic syndrome, first relapse, probably minimum change disease,
Okay.
steroid response variant without any complications.
So steroid responsive. So at this point, can you tell it's steroid responsive? You have not started the treatment?
Yes, ma'am, but the child had before an episode and it was cured,
Okay.
so might be
Okay.
it can be.
Okay. So probably you can say that substantiate.
Yes.
Okay. So, okay, what do you want to do for this child? What all the investigations you want to do?
Starting from routine investigation, complete blood count, renal function test to elevate, sorry, to measure urea and creatinine, liver function test for albumin and globulin levels.
Okay.
Please.
Okay. Can you tell me the definition of nephrotic syndrome, the components, so
So
that
it's
everybody
characterized by
can listen?
nephrotic syndrome is characterized by massive proteinuria, where the
Proteinuria.
urine protein level is more than 40 mg per meter square per hour,
Okay.
and the protein creatinine ratio is more than 2, and dipstick testis is more than 3 plus or 4 plus. There's also associated hypoalbuminemia and hypercholesterolemia.
What are the cutoffs for hypoalbuminemia?
Cutoff is less than 3 grams per dl, no?
And
And for cholesterolemia, it's more than 200 mg per dl.
okay, very good. Okay. So this is something which all of you are expected to know. You should know all the components. Anything else you missed? With
Edema.
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 Okay, it's very significant. Yeah, that's important. Okay.
Yes.
Next.
So blood glucose levels, serum cholesterol and triglyceride levels, urine routine, which includes protein and sugar, 24-hour urine protein, urine protein creatinine ratio, dipstick test, urine culture, chest X-ray, MAN2 test, and USG.
Okay. So why do you want to do USG? KUB? Abdomen, okay? I'll accept. Why do you want to do USG KUB?
Hello?
Yes. Tell me. Why do you want to do USG KUB? Yes, somebody has answered PCKD, okay. So what do you want to do?
Congenital.
See, okay. You want to rule out? You can also, yes, tell me.
Any congenital anomalies?
Okay, congenital anomalies, okay. He's 5-year-old. He already has a previous history of nephrotic syndrome. So, okay, you can say that you want to rule out any infections, okay.
Okay.
Because UTI is one common infection which will trigger nephrotic syndrome, okay. So do you want to do Manto in every child coming with nephrotic syndrome? Yes, no? If yes, why?
In history of TB contact, we can.
Contact? No? See, yes. So Manto is something which is important to be done as routine because you are starting steroids. So if the child is having a latent tuberculosis, the chances that it will flare up once you give steroids. So Manto has to be negative. Even if the child is edematous, you put Manto, you wait, and then only you start steroid treatment. Okay, so that is why Manto.
Yes.
Right. Okay. Next.
So treatment. So oral feeds and child is advised for bed rest for at least 2 weeks. Salt restriction in diet and intake of protein. Steroids. This is a case of relapse. So we follow prednisolone 2 mg per kg daily till remission, and this is followed by 1.5 mg per kg on alternate days for 4 weeks. Can add proton pump inhibitors and daily monitoring of urine albumin, urine input output, and daily weight and abdominal circumference monitoring too.
Okay. Okay, so now this child has come the second time. So if the child does not respond to prednisolone, can you name any 2 drugs which you know other than prednisolone which is used?
Yes, ma'am. Cyclophosphamide, mycophenolate mofetil, levamisole. These are for steroid sparing drugs.
Okay. So at this point, I think at your level, they'll only ask you these questions and not more than that. You don't have to know the doses, but if you know, well and good. And one more thing. So edema. So what do you do for edema?
Diuretics actually not added.
Directly, you will give diuretics?
Usually steroids will make it better.
Yes.
So
IV
this
albumin, somebody
albumin
has
can.
written salt restriction. Okay. See, one thing remember, don't utter the word diuretics in nephrotic syndrome right away. Because see, you should know what is the pathophysiology of nephrotic syndrome. So first you have to assess the volume status of the child. There's already hypovolemia in that child, and you are giving diuretics that will worsen. So you have to check its volume status, and then first you should give steroids, and then even after giving steroids, yes, you can even correct with albumin if it's required, and then you can give diuretics if necessary. Okay, so always don't put diuretics ahead for treatment. So treatment mainstay will be steroids along with some PPIs so that the child does not get gastritis. Okay, so do you want to add anything else along with the steroids for the child? Any supplements? Vitamin, very good. What vitamin? Vitamin C, no? Why vitamin C? Yes, vitamin D and calcium. Very good. Somebody has written, yes. And anemia has to be corrected if it's there. But if the HP is low, definitely anemia has to be corrected. You can give oral.
Okay.
All right. So how will you explain the mother now. This is the first relapse. So let's think that it's an OSCE station for you, and then you have a mother who has a relapse, right? So you have to tell her how to check urine albumin at home, and then because we have to switch to alternate days, right?
Yes, ma'am.
So you should. So will you keep the child until it becomes negative in the hospital?
No.
No. See, so you can expect any questions in the exam like this. So be prepared. You might not even be asked to present, and suddenly they can switch and ask, counsel the mother because it's a relapse.
Yes.
Can you counsel? I'll give you 1 minute.
Okay, ma'am. So your child has a disease called nephrotic syndrome, which is known to have relapses. So this is the first relapse after the age of 3. So it can even relapse further. So we are following steroids for till remission, for which you will have to check the urine albumin. Like you can see if it's frothy urine or not to analyze at home.
Okay, it's okay. So you can either ask them to do a urine routine every morning. That's very important. Early morning, first sample is important for urine. Okay.
Yes.
So, and sometimes what we do is we give them the sulfosalicylic acid, and then we'll ask them to check against the wall. And so these are crude methods which are still practiced in very remote areas. So you should know about it. Okay. So before we move on, I'll take some questions. There's so many. I'm sorry, I missed it. I'll go from behind. You can type your questions. 5 minutes we will discuss, and then I'll switch on to my slide. So aspirin or warfarin might not be required if there is no, yes, it is a hypercoagulable state, but if there is no thrombosis like deep vein thrombosis or cortical vein thrombosis, there is no role of any anticoagulant. But if they have complications, yes, we should consult, decide, and take a call. Okay. So what is the correlation between nephrotic syndrome and pneumonia? Okay, so you should know that in nephrotic syndrome, you lose a lot of complements, immunoglobulins. So the child will be having immunosuppression, and it will also see all these complements are important for opsonization and killing capsulated organism. So in nephrotic syndrome, it gets deficient. So that's why they're more prone for infection. Most commonly will be capsulated organisms because the body will lose the capacity to kill them. Okay, so nephrotic syndrome, yes, anemia is because they again lose this transferrin. So all these things are lost in urine because of the disease per se. So, okay, somebody asked, how could we conclude it as nephrotic syndrome from history? Okay, so whenever you are asking a renal history, so first she gave 3 points. One is it started as periorbital edema, which was more in the early morning, and then it subsided as the day. So if it's starting with periorbital region, it's most probably a renal origin. Then it went into abdomen, and then it went into legs. So gradually it became anasarca, and also there was decreased urine output. So there are the three most common conditions of kidney in children. One is urinary tract infection, but urinary tract infection will not have the swelling like this. The other is nephritic, the other is nephrotic syndrome, so which I will discuss later. Yes. So no, we don't give any statins because of dyslipidemia. This is mainly because of the underlying pathology that it's causing dyslipidemia. So once you treat them with steroids, the edema, the proteinuria, and the dyslipidemia gets corrected. Okay, so hypertensive encephalopathy in children management. Okay, so I think it's out of topic. I don't want to discuss that here because we don't have so much time. Okay. Oh God. Sorry. Should we check for RBC, cast, and occult hematuria? Yes, you can. So since it's a relapse, so we don't know if we are dealing with just idiopathic or if there is any other glomerular causes, probably any membranoproliferative IgA nephropathy or whatever. So Yes, you can see for RBCs. If it is not there, you can probably wait. Okay, pneumococcal schedule. So if the child is less than 6 years, we give conjugated vaccine, 2 doses, 8 weeks apart. And then if the child is more than 2 years, you will also give polysaccharide vaccine 8 weeks later after the last dose of conjugate. Clear? But if the child is more than 6 years, you give 1 dose of conjugate vaccine and 8 weeks later you give 1 dose of polysaccharide vaccine. Clear? Okay. Yes, dipstick can definitely be given to the mother, educated mothers. It's been practiced in most of the centers because we don't want to keep the child unnecessarily in the hospital and get them prone to other infections. Yes, then. Okay. So, okay, so I think I've answered most of it. Can infection cause nephrotic? Yes, definitely infection can trigger, mostly infection. Like any URI only triggers the nephrotic syndrome. So normally when you are given an exam case, so mostly they will have some cold and cough, following which the child would have had. Okay. Yes. Counseling, yes, see, counseling is something which is newly added for your curriculum, so they can ask you for anything. So whatever you know about the topic, be confident and tell. It's nothing specific pattern, so make sure you tell them about the disease process. You have to talk to her and tell them that the relapse is expected here, and then you have to tell her how to take the medications. You should also make her aware of the complications of nephrotic syndrome, and you should also educate her about the vaccines which are important to be given, because that will prevent him from life-threatening infections. Indications for biopsy, yes, there are multiple indications of biopsy. So normally one is the age of onset is less than 1 year, gross hematuria and persistent microscopic hematuria, then low serum complement levels, and persistent hypertension, and if we are suspecting secondary causes like SLE or something else, and then SLE, joint rash or secondary, and there are few more indications. I'll probably check and tell you. So these are the few things which you should know. Right. Yes, it's correct. Vivo, you've written it correctly. Okay. So shall I move on? So I will share my presentation. Srijhaa, can you cancel your sharing so that I can? Okay. Okay. Can you all see? Can somebody tell me if you can see? Yes. Okay. So I'll start. So I know nephrotic syndrome is something you have been studying from second year. So I want to make it very quick. So nephrotic range proteinuria. So early morning urine protein 3+4+ or more than 40 milligram per meter square per hour or more than 1 gram per deciliter. I want you to remember 3 values at this point: 30, 100, 300,000. Okay. So this is what I remembered. So less than 30, 30 to 100, 100 to 300, 300 to 1000, more than 1000. Clear? Okay. Spot urine protein creatine ratio more than 2, hypoalbuminemia, hyperlipidemia, and edema or anasarca. Okay. So classification of nephrotic syndrome. So it can be either idiopathic or secondary. So in idiopathic, there is steroid sensitive. So in that also it can be no further relapse, infrequent relapse, frequent relapsers. And then steroid resistant, primary steroid resistance, secondary steroid resistance, and presumes steroid resistance, and steroid dependent. So secondary examples are like lupus. Then congenital nephrotic syndrome, it presents early in the age with 0 to 3 months. Most common is the Finnish type. Okay, just know the name. So it is due to the mutation of nephrin and podosin. So NPHS1 and NPHS2. These are the gold medal questions. So if you know, it's well and good. Okay, and there are many other syndromes like Denny-Dash syndrome, Pearson syndrome, which are associated, and some congenital infections like congenital syphilis, CMV, and toxoplasmosis might also cause nephrotic syndrome. So these are the common terminologies I want you to revise before going to exam. Remission is urine albumin is nil or trace, that is proteinuria less than 4 milligram per meter square per hour for 3 consecutive early morning specimens. Relapse, urine albumin 3 plus or 4 plus for 3 consecutive early morning specimen have been in remission previously. Then frequenting relapse is 2 or more relapses in initial 6 months, or 3 or more in any 6 months, or 4 or more in 1 year. Okay. Next is steroid dependent, 2 consecutive relapses when on alternate day steroids or within 14 days of its discontinuation. Okay. Okay. My screen is stuck. Okay. So immunization. So live vaccine should be administered once the child is off immunosuppressive medications at least for 4 weeks. So I already discussed about the pneumococcal conjugate and polysaccharide vaccine and also varicella vaccine. So nephrotic versus nephritic. So quickly, nephrotic is, I already discussed these points: low albumin, proteinuria, edema, dyslipidemia, hypercoagulability, reduced immunity. In nephritic, there is hematuria, hypertension, mild proteinuria, mild edema, and oliguria. Okay, so symptoms will have edema mostly, and then frothy urine, fatigue, infections. Here there will be hematuria, hypertension, oliguria. So proteinuria is, nephrotic range is higher, this is lesser. Okay, and then spot protein creatinine ratio in nephrotic will be more than 2, and in nephritic it will be 0.2 to 2. So RBCs might be present mostly in nephritic syndrome, and the causes, most common cause of nephrotic is idiopathic, and in nephritic is post-streptococcal glomerulonephritis. So these are the things I want you to read and go if your exam is on 25th. So you read the pathogenesis of nephrotic syndrome. So why there is hypercoagulable state in nephrotic syndrome, and also management of relapses, management of frequent relapse, and edema management and indications of renal biopsy. I think I skipped one slide. So common complication: infection, spontaneous bacterial peritonitis, pneumonia, cellulitis, fungal infection. So all 4 are common. Other than that, thrombosis, mainly renal vein, cortical vein. Any drug related complications, especially steroids. Steroids will cause hypertension, Cushingoid features, and acute kidney injury. The 2 days were, I did it very rapid so that I'm not taking much time for the exam going. So if the next batches have a lot of time, we can take probably 40 minutes for the discussion and the last 10 minutes for the question. So I can go in detail about the history and examination, but I think most of you would be like in your college level would have done the basics. So I'm trying to cover what is out of the box, because the basic things I think most of you would know.
Yeah. Yeah, thank you so much, ma'am, for this amazing session, and took your time to discuss all
Very
these
happy. It's a
messages
very
and the doubts,
active
ma'am.
batch. So more you are enthusiastic, more it gives me energy to learn, study, and do more. So it's been long. It's been 10 years since I gave my final year exam. So yes, a lot of things have been out of touch for me. So it's good for me to get back to books again. Okay. So yes.
Yeah, thank you so much, ma'am.
Thank you.
We will have our next pediatric session on cyanotic heart disease, tetralogy of Fallot on next Friday, that is on 29th March 2022. We will have some amazing case discussion sessions on medicine from Monday to Thursday. You can refer to the schedule already sent in the AATRAL group. Yesterday's cerebral palsy case discussion recorded video was uploaded in IMA MSN Tamilnadu YouTube channel. You can visit it anytime. Thank you so much, and meet you all in next meeting. Thank you so much, ma'am, and thank you
Thank you.
everyone who
Good
have
night.
participated in this meeting. Thank you, ma'am.